I'm Dr. Tondre Buck from Spartanburg Regional Health System in Spartanburg, South Carolina, Gibbs Cancer and Research Institute. I am presenting today a presentation called the real-world multiple myeloma risk factors and outcome by race and ethnicity in the United States. Multiple myeloma is the second most common hematological malignancy in the United States and the most common hematological malignancy among African American patients. In recent decades, survival has improved for multiple myeloma patients. However, this survival has been slower to improve among Black patients when compared to white patients. African Americans has been associated historically with more favorable cytogenetic profiles. African American race also has been associated with underuse of bone marrow transplant and certain novel medications. Importantly, retrospective analysis of real-world database have found different associations between race, ethnicity, and multiple myeloma outcome. The objective of this retrospective observational cohort study was to describe associations between patients, disease, and treatment characteristics and survival outcome by race ethnicity. The study used the nationwide Flatiron Health electronic de-identified database of multiple myeloma patients in the United States. This is composed of myeloma patients from over 280 U.S. cancer clinics with over 800 sites of care. Included patients were those with race categorized as either non-Hispanic white or non-Hispanic Black, with first line of treatment initiated during the period of January 1st, 2016 until December 31st, 2021. Patient, disease, and treatment characteristics by race ethnicity were summarized descriptively. Real-world progression-free survival, overall survival from first line of treatments were examined by race ethnicity for overall population in various subgroups. At data cutoff, we had 4,387 patients that had initiated first line of treatment. 1,017 patients, or about 23%, were classified as non-Hispanic, Black, African American. 3,370 patients, approximately 76.8%, were characterized as non-Hispanic white. What we found is that the African American patients were slightly younger and higher proportion were female and from the Southern United States. Rates of high-risk cytogenetics and 1q21 positivity was similar between races, as was median time for multiple myeloma diagnosis until start of the first line of treatment. The most frequently prescribed initial therapy in both the transplant population and non-transplant population was PI plus IMiD-based regimen, being bortezomib, lenalidomide, dexamethasone, the most common treatment in both groups, with approximately 53%. We also found that African American patients were less likely to receive a stem cell transplant compared to non-Hispanic white patients, 16.7% versus 21.8%. In terms of progression-free survival, in unadjusted analysis from first line of treatment, progression-free survival was similar between both populations at about 25 or 26 months. In terms of multivariable adjusted hazard ratios for progression-free survival, we found that age greater than 75, performance status, ECOG performance status greater than or equal to 2, ISS stage 2 or 3, were statistically inferior in terms of progression-free survival in both non-Hispanic Black patients as well as non-Hispanic white patients. Presence of high-risk cytogenetics, including 1q21, was similarly associated with worse outcomes in both non-Hispanic Black patients as well as non-Hispanic white patients, but were only statistically significant among the non-Hispanic white patients. In terms of real-world overall survival, what we also found that they were similar. In unadjusted analysis, there were approximately 64 months in African American patients, 59 in 59.7% among non-Hispanic white patients, but similarly overall. The following variables were associated with inferior outcomes in both African American as well as non-Hispanic white patients. age greater than 65 compared to age greater than 65. ECOG performance status of greater than or equal to 2. ISS stage 2 and 3 disease. Estimated GFR of less than 60, and presence of high-risk cytogenetics. As we stated earlier, 1Q21 positivity or addition was only statistically significant in the non-Hispanic white population. In summary, what we found is that in this real-world data-based retrospective review is that unadjusted real-world progression-free as well as overall survival was similar between non-Hispanic Black patients compared to non-Hispanic white patients. For both races, the most common regimen was a PI plus IMI-based therapy, most common being lenalidomide or tizumab-based therapy. Presence of high-risk cytogenetics were actually similar between non-Hispanic Black patients compared to non-Hispanic white patients. Fewer Black patients received stem cell transplant, yet progression-free and overall survival was similar between both races. Association between patient and disease characteristics and outcome were generally consistent between races and ethnicities.